So this session we are really excited to have today for you. It is something that we've been planning for quite a while. We've seen a lot of new issues with our GFPD Warriors and GI over the last several years. And this, we're really pleased to have these panelists here to talk about what we're seeing, and luckily we get to run this session over a little bit. So I'm excited to introduce to you our panelists, including Dr. Rachel Kassel, right here next to me, from the University of Alabama, Birmingham. Dr. Klouwer, who has been here all week from the University of Amsterdam Academic Medical Center. Dr. Lauren Draper from St. Louis, as well as Carrie and Morehouse, one of our own GFPD families, and two of our board members, Ostertag and Corin Chapman. And I really do want you to say a few words about why this panel is so important. So please, hang on.
Sure. So we are having this panel today because I think most parents in the room know we have a lot of GI issues happening, and they are really challenging, and they're impacting quality of life for our children and also for us. We're exhausted. There's so many different things that are happening, and we're not sure what's really working and how to help them. And so we thought we would come together and do what everyone talks about. We're making this happen. We're going to have parents share their stories, share their experiences, what's working, what's not. We're also going to have Dr. Klouwer, who's one of our own on the scientific advisors here at the GFPD. And then we have brought two doctors in who are actually working with individuals that have a peroxisomal disorder and are really facing some really challenging GI issues. So bringing all of these people together, sharing their experiences, having all of you join in this discussion, and really get together and collaborate, and maybe be able to find some ways to recognize what's happening, what could we do? Are there better ways to have screenings more frequently? What types, treatments? So we really think that this is a great opportunity and has a lot of potential to help improve the quality of life for these children that are just having so many different emerging GI issues. We're fortunate enough to have Corin and Chris are going to moderate the session for us.
We wanted to start this off by just generally going through our child timeline. As Katie said, me and Chris are going to be the moderators. But we want to spend a little bit of time going through that timeline so that you can start to think about how that corresponds with maybe some of the GI issues that your child has had. And maybe get some questions going. We really want the majority of this session to be Q&A since we have the experts here. But we certainly want to lay out some of the things that we've been dealt with so that, to get the conversation going. So I'll start a little bit with my son Max, who is 8. His main GI issue started in 2019. And the first bleed that we had internally was due to a high-dose steroid called prednisone that we were using to treat infantile spasms at that time. The way that we knew that it's an internal bleed is because he is G-tube fed, and when we went to go feed him, blood came out. At that time, we were hospitalized. It was seen as a one-time issue linked to the steroid treatment, and we were sent home. I think we were given omeprazole at that time. I say that because he had terrible side effects to omeprazole, and it caused motility issues, general constipation, and he was throwing up most of his meals. So we actually scaled back on the omeprazole and stopped taking that. And then about 3 months later, he had his first esophageal varices burst. And how that presents itself is he threw up a large amount of blood both at home and in the ER. We were hospitalized at that time too, but it resolved itself. They did an endoscopy. They could see where it had burst. They could see that had alleviated some of the pressure that had built that had caused the varices to burst. And we were sent home at that time. You can see I have a list because there's been a lot. Shortly thereafter, we really started that endoscopy where every 3 months we were looking to make sure that they weren't building, that those varices weren't building, and we treated those with injections. A lot of times they do that with banding because Max is is still small, his throat is still small. They weren't able to actually do the banding, so they do that through injections. And I always say it wrong, sclerotherapy, is that right? Okay. Which gets us to 2020, where he started to have much more consistent stomach bleeds. And when we did endoscopies, we've actually never really been able to localize where that bleeding is coming from. A lot of times it's linked to maybe some irritation in the G-tube site, general stomach irritation. But the way that that presents itself once again is when we go to feed him, a large amount of blood comes out. It's usually not an active bleed. We've actually never really been able to isolate an active bleed. It's always post-bleed that we notice it, and then you can tell from the tarry stools, the dark tarry stools, that he has had a bleed. And that's something we've been dealing with fairly regularly. Probably every 2 months we have that happen. We treat that with Pesset. He is on that. That does tend to help. But like I said, about every 2 months he has something like that occur. We've actually never had any blood transfusions. It's never gotten to that level. Chris will talk more about blood transfusions. His vitamin K levels are continuing. We're continuing to treat those as well. We've tried vitamin K injections, but that hasn't had a noticeable impact. And we do that on top of taking ADEC and taking vitamin K every morning. Because the stomach bleeds have been ultimately tied to portal hypertension, so the hardening of the liver causing backup in blood flow. We have discussed doing a shunt to bypass the liver and alleviate that blood flow backup, but we haven't determined that his condition is bad enough to do that. He is currently followed by Dr. Kriegermeyer at Lurie Children's Hospital, and she is a GI hepatologist and nutritionist.
So, as Corin said, we've also had some experience with this. So I'm the father of 2 Corins who turns 5 next week. So happy birthday as well. And our issues really did start in 2019 as well. I think, talking with Rachel, I think in late 2018 was the first time we noticed some blood in his stool, but it was just kind of an isolated incident. And then really soon after the conference in 2019, I think it was really August of 2019, that we noticed these black tarry stools. And I mean like black tarry stools, and definitely out of the ordinary. And we went into the ED, and obviously they found blood in his stool because it was mostly blood. And then they checked his hemoglobin, and it was really low. So in August of 19, I think he got his first transfusion. And I'm trying to recall back because we ended up getting a port really soon thereafter, and it might have even been during that first hospital stay. I don't know if you remember. Yeah. So we were lucky because we noticed, he needed a blood transfusion, and then I think we saw that his hemoglobin was dropping again. He was likely going to need another. So we went ahead and did the port, because many of you know that, getting needle sticks on our kiddos is really difficult and really painful to watch, as a parent. So the port has been life-saving. So in 2019, so the bleeding started in the summer, and these black tarry stools kind of became his baseline stools. And it started out, he was getting transfusions like every 3 weeks or so. And what we were doing is we were checking his hemoglobin at least once a week, sometimes twice a week. And we would just see these steady declines, and then he would get his transfusion, and then he would go back up, and then steadily decline again. And what we saw, maybe after 6 or 8 months of about every 3 weeks, then it was every 2 weeks he was getting a transfusion. And again, this whole time he's having these black tarry stools. He had, I think it was a frequency of about every 2 weeks for probably close to a year. And then it was every 1 week. And we had over a year of every 1 week getting a transfusion, sometimes even like 5 days apart. And it was scary because, you notice that when he gets the transfusion, he doesn't bump up as high, and then it seems like he drops even lower. And all the while, we weren't really noticing blood coming from other places, maybe he's never really thrown up blood, maybe once a little bit, and occasionally you see a little bit of blood coming up around his GJ stoma site, but it's just those black tarry stools. And we had a couple scares. We had one scare in the fall of this past year, and he had diapers full of just red blood, like fresh blood. And it was a couple diapers, and we took him into the ED, and he continued to have, I think, close to 24 hours of these just blood-filled diapers. And at the time, we were talking with GI, and they were sort of hesitant to scope right then, because if something was actively bleeding, they didn't want to potentially aggravate it more. And thankfully, after about 24 hours, that stopped. But during that hospital admission, he got at least 2, maybe 3 blood transfusions because of the volume that he lost. So fast forward to this spring, and again, we were seeing the weekly at the beginning of the year, and then Easter came, and we had like 6 weeks, which it was really weird because Rachel and I almost felt as if something was wrong because he wasn't needing a blood transfusion because we were so used to them. And the black tarry stools have kind of gone away too. So Hans had a blood transfusion like 2 or 3 weeks ago, but last week his hemoglobin was still pretty good. So we're just kind of taking it a day at a time, and yeah. And I know Dr. Draper will talk maybe some more about some of the stuff that we've tried, but that's just a little bit of our time. And just, I would say, I haven't counted exactly, but I think Hans has probably had close to 100 blood transfusions in his life.
Good morning, I'm Carrie, Morehouse, mother of Gregory. Gregory was born in 1991, so I'm gonna say some missteps along the way with his diagnosis, but I do want to note that given the times, he did have a good medical team. But again, 1991, he was born in November and immediately came home jaundiced, and so we thought of the bilirubin lights, and diagnosed with failure to thrive as he wasn't latching on, he wasn't eating, he had reflux, wasn't sleeping, and neither were we. He was crying all the time. So when he was 3 months old, they did an CAT scan of his abdomen to see if maybe there was some. They diagnosed with colic, but it was so much worse than that, of course. And during that ultrasound, they noticed that his liver was enlarged. So at 4 months, he had a liver biopsy, and it confirmed cirrhosis. They said about 1/3 of his liver was cirrhosed. And at that time, we discovered that he had nystagmus, the shaking of the eyes. And so we went in to have his eye checked, and they discovered that he had retinal atrophy. So completely blind, liver cirrhosis. We went in to show Seattle Children's. I'm from the Seattle area. The Seattle Children's were at that time, Dr. Wagner talked about this, they did a skin punch to do a biopsy. And so they sent that to Johns Hopkins. And while we waited, they sent us to Oregon Health Sciences for a more comprehensive look at what was going on. And they wanted to test his hearing and said that if his hearing was bad, it was probably neonatal leukodystrophy. So I'm not kidding you, they banged a pan behind him and he startled, and they said, his hearing is fine, no need to worry about neonatal leukodystrophy. Again, 1991, 92 at this time. So we were relieved, yeah, they did great. So we went home, still waiting for the biopsy results. He was settling in a little bit. I don't know, we were settling in, so he was settling in. Continued to call, biopsy results not coming. So the doctor ordered a beta, brainstem autovote response. You all know that. And it showed completely no hearing at all. So little did they know when they diagnosed that, we now were diagnosed with neonatal adrenal leukodystrophy. But I was still holding out hope, waiting for that skin biopsy to come back, kept calling, and oops, they found it still at Children's. They forgot to mail it. It went bad. Let's do it again. At this point, Gregory's a year old, and yeah, no needles, no hopes. I said, I'm done. We'll take the diagnosis and we'll move on. And he started to progress, so I started to forget about the diagnosis, and this group was not around. And so he, as I said, he was progressing, he was sitting up, he started walking, he was battling, he was giggling, he was sleeping, and his liver, we were going in every other week for clot time and liver function tests, and they started to level out. So I'm like, great, check this off my list of things to worry about, yay. And then around age, so he was about 8 when things started to level out, things were going well, we were really focusing on education. Minor medical stuff, he was never on any medicine until he got older with some pain issues, and we put on gabapentin when he was about 19. So really, no other serious medical issues except for bowel obstructions. Constantly managing, what did Jen say, the diaper outcomes. That was a much nicer term than we used when he was growing up. So really struggled with that. We were in the emergency room quite a bit with bowel obstruction, bowel impact, trying to figure out how to keep that moving along. At age 19, he started to regress. He was having more difficult walking, some more significant neurological issues. Never thought about the liver. He did have a gallbladder removed, but we never thought any more about the liver until about the age of 19 when we started to see some more liver functions coming back. But he was doing okay. He actually moved into a group home when he and his sister were graduating from high school, and my daughter came home from college with a really big life, and I realized that Gregory didn't have a really big life, and so he moved into a wonderful group home that was really caring and was the saving grace when he went into hospice. So at age 24, he started to have, he could not keep food down, just could not keep food down, couldn't figure it out. We did the ultrasound CT again, and the doctor said, oh, there's something going on with his liver. And I thought, well, we've been here before, we'll figure it out. So they sent us, I thought, we'll figure it out. So then they said, we're going to give you an appointment with oncology. Well, I know what that means. So this was November 2016. Gregory was diagnosed with stage 4 liver cancer. I went and got a second opinion because that's what I always did. We're going to figure this out. 3 weeks later, he was gone. So it didn't take very long. And I don't know if there's anything we could have done, but boy, forgetting about paying attention to that liver, again, given the times, maybe there was something more we could do. But I want to share real quickly that because of that, Katie Sokra reached out to me out of the blue one night. She knew me from the Facebook list and said, there's a couple other moms I want to hook you up with sons, older sons that passed away from liver cancer. And that began, she connected these dots. So it's really, I'm so glad that she got us all up here.
I'm Lauren Draper. I'm a hematologist, pediatric hematologist, oncologist, and also palliative care doctor. So not actually a GI doctor. But what's interesting is the combination of, when I think about it in terms of Hans, I really thought about it in terms of bleeding issues. Like, why is he bleeding when your liver's not working? But his liver numbers have always been good. His liver is functioning, but his clotting, he did clot normally, but I couldn't put a finger on it. And even when I would talk to Dr. Draper, who's this GI doctor, he's like, Corin, when I scope him, it's so friable. There's not anything that I can say this is exactly where the bleeding is coming from. This is exactly what's happening. And the thing that I've watched these 3 parents, and they all have notes as if they needed them. I mean, all of you know every in and out of your child from the beginning to every day. And the things that you come to tell us with your children. I think about Hans when I first met him too. I really thought about it we were struggling with how do we control seizures, thinking about here and thinking about these things, and then all of a sudden it's like this bleeding popped up. And at first, I remember even talking to you, like, okay, we just have to get more vitamin K. Like, if we could just get more vitamin K, how are we going to figure it out? How are we going to get it dispensed from the pharmacy? How are we going to get it paid for? And that's going to be the next thing that's enough. And it wasn't. So then how would we put together what this cascade of issues, from bleeding to your liver to varices to what you do on a daily basis and what is reasonable? Probably the most scared I've been with Hans is actually the day when I did a typing screen and he had antibodies and I was like, what happens if I can't give him blood anymore? What if I can't find blood? I had a very similar feeling when we had a blood shortage not that long ago when we were struggling. It's like, he needs this, so what do we do? Because this is what is helping him day to day. Thankfully, his antibody levels, because as you get exposed to more and more blood products, you can develop these antibodies, and it's harder to find blood that you're not going to have a reaction to. His were low level, and they went away, which is I was really thankful for that. But those are the sort of things that how do we triage that from the beginning? We have these kind of emergent issues that seemed emergent, and then these other things kind of snuck up on us, I really felt like. And then we found a balance. And I think the hardest part is from a medical side is, I don't know why Hans is better today. Like, I don't know why all of a sudden he doesn't get transfusions every week. I'm thankful for it, but I really like it. I don't want to forget that side of it and lose sight of something that could sneak up on us. The oncologist part of me, from a liver cancer perspective, is there's so much that we're learning as your children get older. Is when do we start screening? When's the right time? How frequently is enough? How, what's the right thing? Hepatocellular carcinoma, that can oftentimes be a surgical resection and not have to think about, is chemo the right choice? How will our children tolerate chemo? But surgery is tricky when you have bleeding disorder. There's all of these things to weigh, and how do we make those decisions? And I think about it in the context of your entire child. We can't separate the liver from the eating, from seizures, from bleeding. All of those things coordinate. And despite similarities, there's also so many unique differences with each of our children that we have to try to focus on. So that I kind of think about it as thinking about the individual pieces and how it makes up the whole puzzle to figure out the right next step, and trying to stay 1 or 2 steps ahead if possible as a physician.
Yeah, my name is Femke Klouwer, and I'm actually a neurologist, and a pediatric neurologist fellow, but we see around 40 ZSD patients on a regular basis in our outpatient clinic in Amsterdam. So we also do have quite some GI experience from that. But I'm not a GI doctor, so I'm also very happy that we have GI doctors here, so we can hopefully, discuss some of these topics more into depth. But I think there are a few important things that we should already conclude. I would say, very sorry that you had these devastating experiences, and I think that learns already that we first have to acknowledge that there are really GI problems in ZSD. That sounds really logical, but that wasn't really known until, a few years ago. We really didn't know that it was such a common problem, at least in ZSD. So that is, I think, one thing we really should acknowledge. And I think there are 2 important questions related to the GI problems. The first thing is, of course, what is causing it? And the second one is how we're going to deal with it. And the first thing about what is causing it might be very different for every patient. And when looking at liver problems in ZSD, I always, very generally speaking, like to look at it as a crossroad. I mean, there are a certain group of patients who develop liver problems already due to the cirrhosis, usually very early on in life. And I think, but that is also something we should really look into, that it is mainly the group of patients who are seeing the GI bleeding issues, for instance. Then there is this other group, which is, a relatively larger group, hopefully, who has liver enlargement early in life, elevated liver enzymes, but we know in that group of patients the liver enzymes normalize over time or tend to normalize. The liver enlargement gets less, and they can be very well for many, many years regarding almost no liver problems. But in especially that group of patients, the liver problems start later on in life again, but in a different way than the first group of patients, I would say, because that's more like the slowly progressive fibrosis and cirrhosis, and I think that is the group where we really need to worry about developing liver cancer, for instance. So very generally speaking, I think there are 2 groups in that problem. Regarding to the GI bleeds, and I'm also very curious about your opinion on that, I think there could very well be multiple causes. there might be actual bleeding from fractures, for instance, but you can also have ulcers. We have seen that. We think we saw patients that had bleeding from liver cysts, that we know they can exist in ZSD. But then there's also definitely this group of patients, and we heard multiple of them now during the conference, that have GI bleeds, and everybody, keeps looking at the source, but they really cannot find any. And that might be a group that, indeed, somebody already said that, has so fragile mucus and inflammatory processes going on in the gut that it's not like one place you can say that is bleeding, but it might be some sibling, can you say that, out of the mucus all the time on very many places, for instance. And I think that group of patients might be a completely different approach than a patient where you can really find a specific source of the bleeding. So I think that is something we really need to, gain more knowledge and experience about, hopefully soon. And that might also be a group of patients where we really have to look in the more supportive recommendations, for instance, making the coagulation as good as possible, reducing the inflammatory signs in the gut as much as possible. And it struck me that a lot of families I talked to with this problem also mentioned something with the corticosteroids. And I know we have a lot of our patients on steroids because of the adrenal insufficiency. So we also might want to look if there is a correlation between the GI bleeds and the dosage of the steroids, for instance, patients are taking. A lot of those questions I also really don't have an answer for, unfortunately. But what we did is that we, a few years ago, we looked into the coagulation of some of our patients, and we did very specifically look at whether vitamin K intravenously had some additional effect on oral vitamin K. And we did quite clearly show in 5 of our ZSD patients with quite severe liver cirrhosis on an early age that intravenous vitamin K can have an additional effect. So that might at least be one of the recommendations, that in case of a severe bleeding episode, or in case the bleeding goes on, you might actually want to consider give additional intravenous vitamin K during that bleeding episode, or maybe even, like we discussed yesterday, on a regular basis, to at least be supportive to the coagulation as much as possible when you cannot really address the bleeding source. So that's some of my first thoughts on that.
Hey, I'm Rachel Kassel. I'm a GI doc in Birmingham, Alabama, and I take care of Mackenzie, whose family says I can use her name, even though she's not here today. And I'm going to go through this story in detail because I think I can highlight a couple issues. One is all the kinds of tests we've done, which may give other people ideas, but also all of the host of issues that we've thought about. And I appreciate the opportunity to be here at all the things. So let me start by saying Mackenzie has PEX1 mutations, which I think is one of the things when I'm thinking of all the different kids that we should probably think about is what gene are we talking about. So she started having GI bleeds at about 22 months of age. And the first time we did an upper endoscopy so we could look mouth, esophagus, stomach, top of the small intestine. And there was some irritation in the stomach and some bleeding. And my team thought that that was the cause and was trying to blame her steroid replacement for adrenal insufficiency. So then came back a couple months later and had a normal scope. Still having blood in her poop, but then we have a normal scope, so we're all a little confused. A few months after that, has more bleeding, hemoglobin drops. Her hemoglobin usually drops to like 6 or 7 is when we end up admitting at this point. This is a couple years ago now. She's 4 now. And so that time, there's bleeding in her duodenum. So her stomach looks fine on this scope. We're doing the same thing, but there's bleeding in the duodenum. Looked at her whole colon, there was no bleeding there, that looks fine. And we put in a wireless capsule endoscopy, which is a pill cam. It's a pill that for little kids who don't swallow it, we just put it in the duodenum, and then it goes downstream and it takes pictures every second. And we saw nothing in her small bowel. So all we saw at that point was, okay, there's some bleeding at the top of the duodenum, but then we don't see anything downstream. We went on still looking for the bleeding because at this point we're like, all right, we're not finding it, it's still happening. She's getting outpatient transfusions. Talked to experts at various places around the country, so we got a CT angio, which looks at bleeding from vessels. It was totally not helpful. So then we did a bleeding study, which is a tag red blood cell study, and our nuclear radiologist said, okay, we're gonna like really create this fancy study, but we're not gonna just look for a second, we're gonna look for like an hour. And they saw a blush of bleeding in the small bowel. So everybody got excited that, oh, there's something there. But it was only on one of their fancy ways of arranging this study. So then we asked our interventional radiologists if they could go and find the bleeding by going through the vessels, and lo and behold, they found nothing. So we were stuck. At some point during this process, Mackenzie's mom and her pediatrician reached out to me one day and they were like, she's having diffuse diarrhea. It is different than usual and it's bright red. All the other things are black. So we did a stool study and she got herself salmonella from somewhere. So then going forward, we got hematology had long been involved, and we tried things like Amicar to stop bleeding, we tried subcutaneous octreotide, we gave the Colban, we didn't give the Colban, nothing really changed anything. And then at some point, Hemoc said to me, well, can you get rid of the salmonella? Because we think she's colonized at this point, she's still coming back positive. This is many months later. And so we tried treating with antibiotics, and she had a bad reaction, and it didn't go well. And I said, yes, just kids get salmonella. This is a common thing. Don't do it. At some point, we put in a port much later so that we could give these transfusions regularly. The other thing that I should mention is that she did not even have a G button when all this started. We put it in at some point during the process, so we knew it wasn't the G button causing it. It wasn't related to that. Her INR runs like 1.4, and at this point, we're kind of back to the just give her blood transfusion. She doesn't have antibodies, it seems to go fine. And then a couple months ago, I said, okay, it's been like a year plus since we scoped. Let's just go look for varices. And so I did, and I scoped a couple months ago, and I found absolutely nothing on the upper scope. But she's still having blood in her poop, and we're still transfusing every month or so. To address other things that were talked about, I check liver enzymes every 3 to 6 months. I get an ultrasound at least once a year because of the hepatocellular carcinoma risk. I check AFPs to look for, again, it's a blood marker of hepatocellular carcinoma. And then we're also managing G-tube feeds and oral feeds and thinking about eating. So there's plenty for a GI doc to do. Think about all the complexities here. What I think I'm hearing is that we need a guideline for what we should be doing for monitoring. Even if it's not perfect, and it's, in my case, I suspect I'm doing some overkill from what I'm hearing. Like an ultrasound every 6 to 12 months in a 4-year-old, maybe a lot. But I don't know what else to do, and so it may be that we need some expert opinion, and it may just be from consensus.
Share a little bit what we did with Hans for to try to stop the bleeding. Like, yes, I can give blood, but what if we could stop the bleeding? You know, because Dr. Jane would scope and he'd say, yeah, there's all this ribomucosis. Sometimes he would band, sometimes, you know, sometimes there's a little varicose band, but nothing that seemed to make a reliable difference on the need for transfusions. Our primary hematologist and clotting doctor, you know, his clotting time is a little bit abnormal, but not anything that's striking. We always had a FP in our back pocket if there was an emergency to give him extra clotting factors. We tried, what would you say, Chris, like 6 months worth of factor 7 infusions? To say if we gave him factor 7, can we slow down the bleeding? This was when I really worried about antibodies and trying to say, like, can we decrease our transfusions? And Lydia, who's our clotting nurse, she would come to me every week with these graphs, and she's very good with graphs. And she would be like, see, it's not changing. I'm like, give it a little more time, let's try hydrating. And she'd bring me another graph. She's like, it's not changing. I'm like, maybe it is. Then she kept bringing me the graphs, and I'm like, okay, this is too expensive. This is being accessed with this port a couple times a week. Like, this is not working for us. So I agree, like, you almost need a consensus, you know, because I feel like you can extrapolate from some of the other screening procedures we do for other types of cancer, you know, it's every 6 months up until the age of 8, and then starting again at 18, is it, you know, do you do it yearly and then start more frequently again? I don't know the perfect answer, but there's likely got to be something that at least you can take to physicians that may not have that familiarity to say, hey, this is what's recommended. At least once a year we should be looking at these things, or more, you know, whatever that frequency is, to help, you know, as parents navigate the next steps and to help your physicians too.
Yeah, so I think at this point we might, I did have a couple questions written down, and we can also move to the, you know, just general Q&A with those up here. But I am curious about the point around looking at the mutations and then to see if there's a story to be told about the kinds of bleeding that we're seeing. And I'm curious, like, has that been done to any extent, or do you think there's enough patients now where we might look into that?
Yeah, absolutely. I think that's a good point. It has not yet been done, but it is something that the group Nancy Braven will very well be able to do with the natural history study data they have now. So I know they are working also on a liver problems focused article, and that is something they will definitely include in that. That said, we already have, of course, quite some ideas about that. We know those liver problems are mainly seen in certain PEX mutations. So, for instance, like PEX1 is much more prevalent than some other specific PEX mutations. And for instance, we know there are some mutations like PEX10, for instance, where liver disease seem to be much less prominent. So there are definitely some, you know, ideas about that, and sometimes we even tell patients based on that type of PEX mutation, we actually think liver problems might be less of a problem. But of course, yeah, you really need a good analysis of the data to be able to really make clear to really draw conclusions from that. Now it's more like a general idea we have about that, but not like, so we definitely need something like that. But we will hopefully be able to do that.
Okay, so I know that there are individuals in the room that are also having GI issues. I definitely want to give you time to ask questions. So opening up for Q&A, feel free to interrupt. I don't know if anybody else wants to share their story, just so that people have an understanding of all the different tactics that are really being tried at this point.
I'm just going to do the translation for my share. So for Thomas, it started when he was 6 years old. He got COVID, he tested positive for COVID, and he started to have diarrhea, and he started to have blood in his stool. Yeah, he had dark black stools.
So at this point, because Marie-Michelle lives in a remote area of New Brunswick in Canada, she had to get transferred to the closest hospital, which was a couple of hours away from her home. And they admitted him and they did an upper endoscopy, and they saw that it was inflamed and they saw bleeding, but they couldn't find the active site of bleeding. So they got returned home. They gave a medication. I think it was octreotide, and he went back home for 3 weeks, and it was okay. And then after 3 weeks, he started to bleed again, and then he was transferred by plane to Montreal, which is the hospital where we take care of him. That is even farther from her home. Yes, he received a transfusion of blood the first time he went to the first hospital, the first episode. So when he was transferred to the bigger hospital in Montreal, they did an upper and lower endoscopy, and they did not still find any source for the bleeding. So they monitor hemoglobin quite frequently because still today, so this had happened during the spring, and even still today he has some blood in his stools. And so they measure hemoglobin every week, and he's always kind of on the fence when he doesn't require transfusion, but they're never sure what to do. So I think now the plan is to get one for mom to be able to breathe and relax just a little bit, because it's very, very stressful for her. And also Thomas has trouble with coagulation, so he bruises very easily, and mom is always very anxious that if he falls, that he can bleed. Yeah. Yes, so he always had an elevated IVR. Thomas was always in the range of 1.5, 1.6, which is pretty elevated. And he was on intramuscular vitamin K, but they had to stop doing that because he was having big bruises. And he still today, even after 10 months of stopping the injection, his thighs are all bruised still from that. And it's really more in November 2021 that they noticed that when he would hit himself, he would have big bruises, and it was being a problem. Okay, that's it.
Did anybody else have any questions they want to share? So I'm Mama Patrick, and we just started out on our GI journey not too long ago. He had his first bleed in May. For a parent just starting off in the GI world, with our first GI bleed, what would be the recommendation for our first steps? So what we did when we were in the hospital was we monitored his hemoglobin and hemocrit. And when those stabilized, they sent us home without actually doing any kind of scope, because that could have caused more harm than good. So what would your suggestions for me be going forward?
So I'll preface this with, I'm not supposed to give medical advice on that, all those things. So I think the first question is it variceal or is it non-variceal? And the only definitive way we can know that is by scoping. And if it's variceal, we can do something. We can potentially band, or we can do sclerotherapy, but we need to figure out that difference. Now, there is definitely an argument to be made that in an active bleed, sometimes all I can see is blood, and that's not a useful scope. But we know what we're all saying is that there's liver disease that then leads to increased pressure, which leads to variceal bleeds. And then there's something else going on that I think we're all very unclear about what something else is. But figuring out those two ends of the spectrum seem like a place to start. Then the other, that's for me as the GI doctor. Then there's the hematology part.
Yeah, I think really trying to have a good hematology evaluation for how is the coagulation cascade working in your child? And is there a point at which we can intervene, whether it's higher doses of vitamin K, whether it's oral or IV, there's a lot of varieties, or if it is factor infusions, or even other hematology things that we thought about. We gave IV iron to Hans at one point to say, can we help him produce enough red blood cells? Because his iron was low because he was bleeding so frequently. So really kind of taking that approach from bleeding and then also overall iron store and blood loss perspective, I think about too. As a parent, what do you guys say?
I mean, I think being connected with this community, you know, like many of you know, like I mean, a lot of us frequently are on the Facebook group, and you know, I always think about all of the particular instances when we had questions that we actually found answers from you all and from this community. So I think that just you know, seeing if others have had similar experiences and then what they do in those cases, and just being staying connected to all of us, because we definitely learn from one another.
Yeah, and I'm kind of what's the crisis? And so for me, it's having those conversations with your doctor. If there was a crisis, what are the next steps? And who do I need to call? Who do I need to loop into those conversations? For us, you know, we have a post-it in the cabinet that says, you know, if Max has this bleed, he needs octreotide, here's who we need to incorporate into that conversation. And that gives me peace of mind, just if anything were to majorly happen. And I'm actually curious, so Max has been prescribed Hubsid, and it does seem to help quite a bit. And I'm curious of how often that gets prescribed, and if that's been helpful. Has it been helpful? Yeah, okay. I mean, I think that's even helpful to know. And for me, it's knowing too that omeprazole has a lot of side effects. And we've had, you know, terrible side effects for Max with that.
Well, and back to the guidelines point earlier, I think it would be really helpful to get a sense of what everyone is doing and has done, so that we can sort of see what's worked, what's been tried. Because again, I think a lot of us, you know, I think of when we were trying to figure out the right medication regimen for seizure control, and everyone here has been on a whole different combination of different drugs. But it's like, if we're aware of what people have tried and what's worked, then we can try them. And like, I don't think Hans has been on the Pepsi. Yeah, so maybe that's something we'll try.
I feel like, I should have added myself. I feel like we kind of knew what we needed, and this important conversation we're having today is affirming that, and that we need to move forward in some more formal way, because we can give these recommendations. But I myself as a parent know that sometimes we're sitting in that hospital room, that exam room, we can't say, well, my friends on Facebook told me. That's not going to be able to, that's not going to give the validity that we need for the doctor to order these tests or prescribe medication. And so that's where the treatment guidelines and the publications that the GFPD has helped create and make happen can really help us on a day-to-day basis when we're in these hospital rooms and we need to share with doctors who've never heard of this disease. Hey, this is what is recommended, and that's what we need in this area.
So until we get those guidelines set up, how open are you guys, the physicians up there, to receiving contact or receiving, you know, having somebody like my daughter's GI doctor reach out to you if I was to give her your name and say, you know, so-and-so has treated a similar issue, maybe you should reach out to them. I mean, is that something physicians do and that you're comfortable doing, or is that something that's kind of like, we don't want to talk to you?
No, I mean, at least from my perspective, that's what we do. We're a community. I think all pediatric subspecialists that treat complex, complicated, rare disorders, we share information, we put our heads together, we have to, is my perspective. So absolutely, I mean, I reach out to people for questions. They should also reach out for all of that. We don't think we right. Yeah.
Yeah, because once you get in the adults, you start all over again because this is a great community of pediatric folks. Sorry, I see that talks a lot anyway. But I think it's really important because when Gregory turned 19, we were no longer in the children's system where, despite some missteps, I still had this team, and then I had to go find my own neurologist, my own GI, and they weren't even in the same building, they didn't talk to each other, so I think that's also another protocol that needs to be, that somehow there's this system that transitions your kiddo into the adult service system with all that information. Even though, like Katie said, as a parent, I'm giving them all this information, they don't, sometimes they don't think that I'm his best. I'm not a medical person, so.
So the transition of, I have a lot to say about transitioning. Yeah, we could spend a whole conference on that, but I think that complex medical care program should really start talking about that when your children are 10, 11, 12. Even if there is no intention, there are some diseases that we keep forever at the pediatric hospital because of the nature of the diseases. But that's going to be individualized to each healthcare system. But it should be a very young and childhood start to that conversation about how they can prepare for that transition, because it literally does take years to do it properly. And or if it needs to, it may just be, okay, only neurology has to transition, or only GI because our pediatric GI doctors can feel comfortable scoping after a certain age, if that's the case in each of your medical homes. But having that conversation earlier is so important. There's a lot of ways to do it well. I think we're not good at that.
Hi, so my son Ryan, he's 8 years old, and he began having some issues with his hemoglobin about 1.5 years ago. He always lived around 12, 13, his hemoglobin, and then all of a sudden it dropped to about 8, 9. So we began with iron infusions, and they did an upper and a lower on him, and again, kind of like you guys were mentioning, really wasn't anything notable on that. So after a couple iron infusions, he came back up to about 10, 11. Everyone was pretty happy with that. He was doing well. All of a sudden, 6.2, like out of nowhere. And so we did a blood transfusion. We did 3 iron infusions, and actually next week he has an appointment with hematology. GI's kind of been guiding this up until this point. And I was just wondering if you could speak a little bit more about factor infusions and kind of what that looks like. And then also just to mention, his INR usually lives like 1.1, 1.3.
I'm going to hand this over in a second, but one question to start with from a GI perspective: do we know if the blood is coming from his GI tract?
I have so much information. I'm trying to keep it brief. Yeah, so actually the first time his hemoglobin dropped, hemocols were positive. The second time with the drop, the hemocols were negative.
Well, I think you hit on the complexity, and I think if it's hemocult negative, it might be my problem as the liver doc, but probably not as the liver doc, is what I would say. So I think that helps us get to the where is the bleeding from, and we may feel ridiculous doing the same test over and over again, but I think we always gotta remember: is it that we don't have enough iron? Is it not enough, or is it that we're losing it somewhere? Those are big categories that are kind of simplified by me as the GI doc, but and it may be that we all have 2 things going on too.
And so from a factor infusion, first you kind of have to stratify what factors are low or deficient. So some of that is going to require testing. The problem, FFP is like just a bunch of fresh frozen plasma. It's just a bunch of pooled factors. The issue with that is it has a pretty short half-life. So if you need pooled factors, it's really great for an active bleed. It's not great for a long-term solution because you need it so frequently to really be helpful. But we'll do some of our bleeding tests and like our clotting, some of our bleeding tests before and after FFP. FFP infusion to see if it changes things, which can be a helpful pre and post. And then if we can identify a specific factor deficiency, it's like when you think about hemophilia, which is just a bleeding disorder, is a factor deficiency, I can fix it by giving you that factor because it's not multifactorial. And I think that is the thing that we're struggling with, that thing that we can't put our finger on. It's not just variceal bleeding, it's not just the liver, it's not just that you could address that problem. That said, if you can help it a little bit, it may be enough to push you over to kind of a level of stability. And I think that's what we were really trying to pull upon. Is it going to be factor 7 infusions that give us just enough that maybe we don't need transfusions so frequently? And we had a little bit of evidence of some factor deficiency, and then we had a nurse that was really good at fighting the insurance company because they're just so expensive that it's hard. You have to fail so many other things before we can really get them covered and get them covered at home. So I think that's the other piece that a consensus guideline can really help with, is to help fight with insurance companies to say, we need to have this, we need to try this, and that it does hit home a little bit different than the group says. It's like, no, this is consensus guideline, this is what we've come up with, is the best thing to do right now with the knowledge we have. I don't know if that's
And I'm not sure, I was just going to share really quick and I'll bring it to you. I don't know how much I have to step out, so I apologize if this is repetitive, but I asked Carrie to be part of this panel because she lost her son to liver cancer. And I myself have a son who is 20 years old, and as I'd say about the age of 15, we really started having really abnormal liver ultrasounds. And it was countless, it was numerous. They couldn't even tell us how many lesions he had throughout his liver. And so he was a child who had very abnormal liver function, very enlarged liver at probably around 18 months, 2 years age. And he's always had coagulation issues that have fluctuated. Leads have not gone good, a huge issue for him, but he's had that fluctuating liver function. And when I heard that Carrie's son had passed with liver cancer, and know that when I share about other families that have liver permission, there are 3 families now that have had the diagnosis of liver cancer. And I have a doctor say to me, because working with GFPD and working with the families and having this knowledge, I wasn't blindsided by that. But when I went and had a new physician in South Carolina say to me just very recently, well, he'll probably get liver cancer. And that it jarred me that this person said this. And I said to Femke, Klouwer, I shared this information, and she said, wait, I don't think that should be a huge fear. So I wanted to make sure that she was here and share her story, because the last thing we need is added fear. We have enough anxiety, we have enough to deal with PBD. So I want to make sure that her story is told and that we're aware of this, because I don't want another family to be blindsided with a doctor who may say that to you, because we are seeing some individuals with that prolonged survival have that cancer diagnosis. Is there anything you could share, Femke, to be able to?
Yeah, I guess we totally agree with you. And we know now hundreds of families, I would say, with a child with ZSD. And we came across, I think in total with the Dutch and the US population, which are the populations we know best, around 5 patients, I would say, with liver cancer or most likely liver cancer. And that is, every patient we know for, the last 30 years. So it is definitely something we think we should be very aware of, because if it would occur, we want to, of course, find it out as soon as possible. But I would not say that the message should be that we all should worry for liver cancer at a certain age. Chances of not getting liver cancer, based on what we know now, are still a lot bigger than getting liver cancer. And the underlying cause of the liver cancer is, it is well known, it's cirrhosis, other causes, which probably better, of course, that liver cancer can occur on the background of liver cirrhosis. So it might very well be secondary to the liver cirrhosis seen in this disease that liver cancer can develop, but it's definitely not something that is like a very prevalent.
Okay, so I'm still don't worry about it. Sorry. So what's the associated path of care? So is it an ultrasound every 12 months once they turn 12? Like, is there some recommendation that you, and it doesn't have to be like this is set in stone, but some sort of high level recommendation that I can walk away with?
Yeah, I think there actually already was something about it in the guidelines, the original guidelines, but we should also update that, I think, in the common guidelines. We recommend an ultrasound every year, from diagnosis anyway, also because of other reasons. Because you will have to look for kidney stones like every year anyways. So I would say also from a practical point of perspective, to also look for possible deficiencies every year when you do the ultrasound anyways. Sometimes in some of our patients with, for instance, a very mild phenotype, with, for instance, homozygote GFPD mutations, we start doing the ultrasound every 2 years, for instance. But what we do, but I know that it depends a bit on what part you are in the US, but it should be something maybe we should include in the guidelines that if possible, we should perform that. Is we do fibro scans every year to have also an idea about how the possible liver fibrosis or cirrhosis is developing. So if you know there are no signs of cirrhosis on fibro scan, you also have an additional argument that you should probably be less worried about developing liver cancer. And if we know that a patient already really has scores with FibroScan that fit with cirrhosis, we are more aware and more, we really make sure that we do the proper screening. So that is something that can also help you a little bit in determining how frequent you should look. But from a practical point of perspective, I would say do it at least every year since you don't do that anyways.
And I would say from a practical standpoint too, hepatocellular carcinoma, like when we say liver cancer, from a pediatric oncologist, I think hepatoblastom, that's much more common in the pediatric arena. So I think there's going to be less familiarity with pediatric providers with HCC and following that and looking at that, because you can develop liver lesions that are not cancerous. And then how do you follow those when you pull the trigger to biopsy? There's a lot of it's not perfect. I think doing the ultrasound is kind of a first step, and then there's a lot of other layers beyond that too.
Find the lesions, of course, you should have proper workup to define lesions, but as a screening point.
And we did move forward once we had so many lesions. But the ultrasound tech was actually fascinating. They said, I've never seen anything like this before. So I don't know what they were presenting, they were fascinated. But we did move forward on the biopsy. So my son, his name is Jeremiah. So he's kind of on the mild end of the spectrum. His mutation is PEX11B. So it's more rare, and they don't have a lot of cases about it. So I'm trying to kind of direct his GI doctors where to go as far as he's not had issues with like GI bleeding, but he's more having issues with like chronic diarrhea, and then also more recently issues with swallowing. At times when he eats, he may throw up or he may gag. They haven't done, I live in Maryland, and it's trying to explain this to his doctors and stuff is becoming hard because they just like, they write it down as a diagnosis, but it doesn't seem like anybody's really researching it to figure out the steps that they need to take to follow him as he gets older. He's currently 6 now, and besides like mild intellectual delays and short stature and stuff like that, and feeding issues, he hasn't had too many issues, thank God for that now. But he's recently started getting this chronic diarrhea and stuff. They keep testing him for celiac disease, which he becomes negative for. So are there any other things that I need to tell his GI specialist to test for that may help in the long run?
So the other hat I wear is as the GI doc. So common things being common, totally unrelated to Zellweger. When you tell me about a kid who's having trouble with solids and who's vomiting some, I think about something called eosinophilic esophagitis, which is like eczema of the esophagus. And it's something that we joke in Alabama every child has because we follow hundreds of kids with this. It's a kid thing. And so we scope, we diagnose it, and we treat it. There are papers showing that even in kids who are neuroatypical, that we still find this condition like 20% of the time. So basically, my take as a feeding doc is don't forget the common stuff that all the other kids get too. And then when you're talking about diarrhea, we think about kinds of stuff. Is it related to his intake? Is there something going on with his colon? You're going to go do an upper scope. Is it so hard to add a colon? So lots of just general stuff we think about as a GI doc, in addition to the Zellweger. So yeah, so swallow study usually is useful. If we're going to aspirate, we're more likely to aspirate liquids than solids. So I don't usually get a swallow study for solids. I might get an esophagram and look at the esophagus and make sure stuff's going down okay, but I'm not too worried about going down the wrong tube. It's more direct.
I just want to say thank you for saying that, Dr. Kassel, to remind everyone, because I think that happens so often. We have such complex rare cases that it's easy to forget that there's general typical things that are just overlooked all the time because we're just going deeper, and it's really just something that happens to kids.
Monkey is pretty mild. The only thing that we've really dealt with so far is the elevated liver levels. And I've asked our hematologist about vitamins and things like that, and he's kind of pushed it off. So I just wondered, but he didn't really give us a reason why or kind of educate us on that. So I was just kind of curious how that affects the liver or any kind of GI issues, if it does at all.
Yeah, I think I want to make sure I understand your question. If you're asking if vitamins can help make the transaminases better, I would generally say no, we really don't have data for that. There's a little bit of research in fatty liver disease, which is a totally different condition, about using vitamin E. But the question that I've had, and that I'm just kind of dealing with the knowledge that we have, is if there's challenges with cholestasis, then we definitely supplement with fatty acids. If we have bile acid synthesis problem, should we just also supplement fatty acids because it's, or supplement fat soluble vitamins because it's only enough, so ADEC or vitamin K. I think.
Yeah, in addition to that, I have to agree, but in addition to that, we also know in ZSD that there is really a problem with fat soluble vitamin absorption because of the bile acid intermediates that are there. So the gut is less well able to form the little little lipid drops that are needed to absorb the vitamins. So indeed, the ADEK should really be looked at whether it needs supplementation. And not all patients do need supplementation, but it definitely should be looked at. And we also advise in general to look at it once a year.
Then I got one more question. So we all know how resilient the liver is, and I guess kind of my question would be, is the research that goes into, like, say, liver transplants, like, is there a chance that, sometime in the next 20 years, that's going to be on the table where, they can grow another liver for, any individual, and, and that just be something that people don't have to worry about anymore? Is that like at the forefront of any kind of research, or?
Well, that is a very good question. I can maybe tell something about that because actually there has been some experience with that in ZSD. So in Belgium, there has been a few patients with ZSD that have gotten like a partial liver transplant. So they transplant part of the liver from parents to the child. We cannot rule out that it might actually do something for ZSD patients, but unfortunately, at this point, with the data we have from that experience that the Belgian had, we cannot conclude there is any clear effect. So we have had discussions with them before and also advised them to really proper follow-up with the patients after the transplant, because we really would like to know, of course, how they'll be doing and whether we have any indication that it might be beneficial. But so at this point, I would say no.
Okay, so I guess it's kind of hard to understand because of, people doing heart transplants and taking, say, a valve from a pig heart and putting it into, a person. And it's just hard for me to understand how, science and doctors are able to do that. But, I guess I don't understand what's the hold up on the liver. Being as it is such a resilient organ and, a heart, comparatively is not.
What is a problem in ZSD compared to other diseases where you might consider a liver transplantation is that the disease continues. So you keep having those toxic metabolites, like the ferrous chain fatty acids, the bile acid intermediates. So that is why it is not too certain whether a ZSD patient could actually benefit if you would already be technically and like all the other problems related to a liver transplantation. If you would already be able to perform that. So that is why that is not so certain in a ZSD. But it's definitely an approach that has been, that people have been interested in looking into that, whether that could be beneficial for a ZSD patient. Yeah.
All right, so I wanted to thank the panelists so much for being here. We absolutely, this has been an invaluable conversation that has probably needed to happen for the past few years and has given us, to Katie's point, a lot of milestones that we need to really focus on going forward so that we can have some level of recommendation when these sort of things occur. So thank you very, very much for being here. And let's give them a round of applause.